Good afternoon, everyone. This is a case report of Aspergillus brain abscess in an immunocompetent pediatric patient. Aspergillus brain abscess is a challenge to diagnose and treat as it is a rare clinical condition. It usually occurs in immunocompromised patients. This is an unusual case report of aspergillosis in the central nervous system in an immunocompetent child. An 11-year-old boy was brought to the pediatric OPD with complaints of irritability, sleep disturbances, and failure to thrive. There were no recurrent infections or chronic illness in the past, and he was immunized according to the IAP schedule. There was no significant maternal and postnatal history. The child was initially admitted in a pediatric hospital with suspected MISC. Later, he was diagnosed with sepsis by Candida glabrata. Later, he developed spontaneous bowel perforation with peritonitis, for which he was treated with colostomy, and he was given methylprednisolone and intravenous antibiotics. He weighed 16 kgs. He was conscious, occasional irrelevant speech. He was emaciated. His vitals were stable. Per abdomen examination showed colostomy in situ. He was moving all his limbs with restriction at joints, and there was occasional irritability. However, there were no focal neurological deficits. His complete blood picture was normal. CRP and procalcitonin were elevated. MRI of the brain showed a well-defined irregular lesion measuring 3.7 into 2.8 centimeters in the left frontal lobe, involving the middle and inferior frontal gyri of the left ventricle. CT brain showed a well-defined hypodense lesion with peripheral hyperdense rim noted in the left frontal region with mild edema, which is suggestive of an abscess. Paired blood cultures for bacterial and fungal growths were sterile. He was HBsAg negative, HIV and HCV non-reactive. He was treated surgically by left frontal craniotomy and excision of the lesion. They found a thick walled abscess with clear margin of surrounding edema with pus inside. The pus and the tissue bits were sent for microbiological and histopathological investigations. The bone was fixed with nylon. Ventricular wall was breached, which was closed with muscle. Post-surgery microbiological investigations. Gross appearance of the pus showed multiple gray, white to gray, brown, soft tissue bits and pus showing yellow necrotic areas. 10% potassium hydroxide mount showed plenty thin, septate, acute angle branched hyphae seen. The sample was inoculated on Sabdot's dextrose agar. After 4 days of incubation, colonies were granular, flat with radial grooves, yellow at first, which later turned green with aging. The colonies were examined by LPCB mount. Thin septate hyphae were seen. Conidiophores were hyaline and roughened, bearing a vesicle. Phrealides were borne directly on the vesicle in a uniseriate pattern. Conidia were globose to subglobose and arranged in chains. Histopathological sections showed fragments of brain parenchyma with central necrotic areas and colonies of slender, septate, acute ankle branching fungal hyphae surrounded by neutrophil aggregates, foamy histiocytes, extensive foreign body, giant cell reaction, and lymphoplasmacytic infiltrate. Histological features were consistent with fungal abscess, probably of Aspergillus etiology. The patient was shifted to PICU. He was kept on medical management with antibiotics and antifungals. Antifungals were continued as per pediatrician's advice. The patient was shifted to room and he was allowed for discharge as he was conscious, alert, obeying commands, and he was vitally stable. On discharge, he was advised to take voriconazole 100 milligrams tablet twice a day for 14 days. He was given other supportive treatment like multivitamins, paracetamol, and antacids, and warning signs were explained to the mother. Fungal infections of the central nervous system are rare clinical surprises. They are frequently mistaken as tuberculous meningitis, pyogenic abscess, or brain tumors. Aspergillosis should be considered in cases manifesting with acute onset of focal neurological deficits resulting from a space-occupying lesion. An aggressive approach to diagnosis and rapid vigorous therapy may hope to alter the clinical course in the pediatric age group. Thank you.